Well, good morning, everybody. I'm glad that you have joined us. We have over 150 people on the line right now, and we are expecting more to join in the next few minutes. We would like to get started, and I am very much looking forward to our presentation this morning. This is truly a collaborative effort, as we have presenters today from Alberta Health Services, as well as from the Holland-Bloorview Kids Rehabilitation Hospital in Toronto. So we have had many minds come together to create the material for today and for our follow-up session to happen for our part two, and looking forward to the conversations that are to arise from that. So welcome. My name is Sharon Spicer. I am a pediatrician in Calgary, and my work involves working with children with complex medical conditions, particularly with eating, feeding, and swallowing problems, and those who have their feeding provided through the enteral route. And so that is my interest in this work. And of course, as many of you do, I encounter children with autism who have difficulties with eating, feeding, and swallowing. So the messaging today will be very helpful for us. And the title of the talk is Getting the Info and Figuring Out What to Do with It. So I think that there will be ample time today to hear from our speakers and to be able to ask questions of them and get some questions, and then we will be following up with a second session. Vanessa, are you able to forward the slides for us?
Yes. Are you seeing the slides?
I am seeing slide 1. Are others seeing the slides advance? Okay. Thank you very much. So here is a list of our objectives for today. We're going to be talking about important points to consider when assessing eating, feeding, and swallowing with a child on the autism spectrum, and how to bring together assessment information and form appropriate goals. And we will be doing this in part through case study presentation, bringing together the assessment details, synthesis of results, and application to treatment.
So Sharon, I'm advancing them, but I wonder if you've got a version of the PowerPoint on your side. Maybe look at mine at the same time.
It seems, sure, it just seems like there's a little bit of a delay on
A
my side.
lag. Yeah.
We'll get that worked out as well.
Okay.
So I do want to acknowledge that we are working and living on, from my end, Alberta, which is the land of Treaties 6, 7, and 8. We are living and working on the traditional and ancestral territory of many peoples. We acknowledge the many First Nations, Métis settlements, and Inuit who have lived in and cared for these lands for generations. We are grateful for the traditional knowledge keepers and elders who are still with us today, and those who have gone before us. We make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting. From Holland-Bloorview, they have provided us with a land acknowledgement as well, which I will read here also. We're currently working on the traditional territories of the Mississaugas, of the Credit First Nation, the Wendat Nation, the Batoon Nation, and the Seneca Nation, also a part of the Haudenosaunee Confederacy. When we think of our commitment to reconciliation, we think of Indigenous communities with food insecurity, health inequities, and limited access to medical services. We do a land acknowledgement to renew our personal and professional commitment to work towards dismantling health inequities within these communities and other marginalized communities. Thank you for that. So I'm sorry, I'm a little bit out of sync with the slides, it seems. I think I have where we are now, and we're at some housekeeping items. If you have comments during the presentation, please write them into the chat box and select all panelists and attendees if you want to make your comments publicly visible. Today, we are booked for a 1-hour session plus a half hour for a percolator time. And so we will be using the last half hour for informal questions and answers. And certainly during that time or before, you can use the question and answer feature or raise your hand, and then we can include your questions in our discussion. We also have a certificate of attendance available to you. And if you would like to have this for recognition of professional development, please email us at peas.project@ahs.ca and we can provide that to you. I'd like to give you a little bit of an outline of what the scope of the PEAS project is before we get into our discussion today. The Pediatric Eating and Swallowing, or PEAS project, is a provincial quality improvement initiative with the purpose of developing clinical pathways to standardize and improve the care of children with a pediatric feeding disorder, as defined by Godet et al. In JPGN in 2019. For this phase of the project, our target population is children in the ambulatory care settings, so we focused many of our resources on outpatient and community care, but they can very easily be applied and adapted for other care settings such as acute care as well. So our conversation today is one of the initiatives to come out of the PEAS project, and there are many more as well, and you can find them at peas.ahs.ca. That brings us now to being able to introduce our speakers and our topic for conversation today: eating, feeding, and swallowing for children on the autism spectrum, getting the info and figuring out what to do with it. I'd like to introduce our speakers briefly. There is in the chat a link to their bio so you can find out more about them. In brief, Christy Raphael is an occupational therapist, Rebecca Perlin, a speech language pathologist, and Dr. Sharon Smile, a pediatrician, all at Holland-Bloorview in Toronto. And Courtney Majowski is a speech language pathologist at the Glenrose here in Alberta Health Services. Very happy to have you all with us today. And with that, I will turn it over to you for your presentation.
Thank you. I'll just ask Rebecca to share the slides as she'll be supporting
Absolutely.
the technical side. Thanks, Rebecca. So thank you everyone for being here. We're totally excited as a team to present collaboratively today. But before we start, I just want to mention, especially we have lots of speech and language pathologists on today, that language does matter. And throughout this presentation, we're going to be using some identity first language, referring to autistic individuals, as well as there's person first language, referring to person with autism spectrum disorder. So just respecting the autism community that might be here as well, listening in. Let's begin. So we're tasked to talk a little bit about feeding, the assessment of feeding issues in autism spectrum disorder. We know that feeding difficulties are common in autistic individuals, and there are lots of varied terms and presentation that you'll hear in the literature, see on the Google University. And so we hear terms like food selectivity, food sensory issues, problematic mealtime behaviors, rigid food preferences, and fear of trying new foods. All of this being said, it's important for clinicians to be aware of the presentation of feeding difficulties in autistic individuals and the negative health impact that is noted for both not only the child, but also family members. Often we hear the term picky eating in conjunction with autism spectrum disorder, but this term can be very harmful because it suggests that something that occurs in early childhood, it's transient, not impacting function or impacting physical health. But in autistic individuals, we know feeding difficulties, which include restrictive eating and avoidant eating behaviors, impact health negatively and does impact function. So it represents a clinically significant concern. What do we know thus far? We know that feeding difficulty, primarily food selectivity, is 5 times more common in autistic individuals compared to individuals with an intellectual developmental disability. The prevalence is varied, and you'll have reports from 15% all the way up to 95% of individuals on the spectrum having a feeding difficulty. What that means is that clinicians need to have a heightened index of suspicion, and we need to ask individuals about their feeding behaviors or eating patterns when we see them in our clinical encounter. Our team, we often say food intake is a vital sign for autism spectrum disorder, because you cannot tell about a child's feeding challenge just by looking at them, because anthropometric measurements are usually normal. What else do we know? We know that kids prefer carbohydrates. They love processed foods like crispy, chunky, crunchy snack vegetables. We know that they prefer foods, and they decide what types of food they eat based on its texture, appearance, taste, smell, and somewhat the temperature of the food. But over 69% of kids are reluctant to try new foods. So in any of your clinical encounter, inquiring about that child's relationship with food and encounter with food is going to be key. Even though we're speaking about feeding issues in autistic individuals, it starts from early childhood, but there's some chronicity with this. It follows through to adulthood. And so it's important for that intentional review and continuity of care when it comes towards looking at feeding behaviors. Next slide. Thank you. So why does it matter? It matters because this is a chronic issue, and it matters because there are lots of comorbidities for us to think about. There are significant negative health outcomes associated with feeding difficulties. So we know that there is an increased prevalence of obesity in autistic individuals, significant gastrointestinal problems that we'll speak about later. We know as well that there are differences in vitamin, minerals, as well as macronutrient intake. So we can have iron deficiency seen up to 32% of kids, iron deficiency anemia in 16% of kids. And it doesn't only stays within the lab abnormality. Remember, iron deficiency anemia may present with lethargy, impacting that child's academic performance and engagement with social interactions within the school environment. There are other vitamin deficiencies and low levels that are noted, that of vitamin D, vitamin C, B12, and vitamin A. And no one wants to have vitamin A deficiency because the end outcome is blindness. So if we have a higher sense of index of suspicion, we're more likely to identify kids who are highest at risk. And hopefully through this presentation, clinicians presenting here or attending will be able to identify kids at risk in the community. Next. Next, Rebecca. Okay, one back. So we speak about feeding challenges in a pediatric population, but as we alluded to earlier, it follows into adulthood. And I really like this paper because it tells you about health status of adults on autism spectrum. And I identified and localized just the gastrointestinal complications that are here. When we look at this paper, we identify that an autistic individual is 3 times more likely to have constipation, 1.8 times more likely to have gastroesophageal reflux disease, 2.6 times more likely to have some symptom concerning with nutrition, metabolism, or development, and 2.3 times more likely to have vitamin deficiency. So the implication is that long-term risk of physical health conditions secondary to impact of poor dietary intake is real. And it is the indication for clinicians to be aware, to assess, to monitor, and also to ensure that there's some continuity of care. Again, food intake is a vital sign for autism. So often in autism spectrum disorder, when a child presents with a concern, we tend to use a behavioral lens or skill deficit framework to ascertain the cause and to guide treatment. But when we look and approach feeding issues in the autistic community, we have to think of feeding issues as a medical issue first, right? So the approach to the assessment of an autistic individual with a feeding issue should always be rule out medical issues first. Next. As such, you should think of feeding challenge as a symptom, not a problem. So when a child presents with a cough, what we tend to do, we don't just treat the symptom of a cough, we complete a comprehensive assessment and possibly find the underlying causes of the cough and systematically rule out or rule in each possible cause. So obviously, the more successful we are at identifying the underlying cause of the cough, the more successful our treatment will be. This approach is the same approach that should be used or applied when assessing feeding challenges in autistic individuals. So Rebecca, myself, and Christy, we sat around and thought about what are the things that we're seeing whenever we have clinical encounters with autistic individuals presenting with feeding challenges. We found that we identified lots of medical issues, nutritional factors. Some kids may present with oral motor differences, behavioral challenges. We identified that there are environmental factors. And we also looked at parent-child interaction as being something that really impact that feeding process. And also to think about culture and parents as well as youth and children, how they interact with foods and what types of foods, especially when we're thinking about our food diary or food plate or food pyramid, how is that applicable to that population and to that individual? So the challenge is that there's currently there's no established method guiding clinicians to complete a comprehensive assessment. And so what happens is that many clinicians will do what they're best at doing. So whenever there's no guide, what happens is that there's inadequate, you can proceed, Rebecca, without adequate framework for assessment, clinicians are left to guess how to proceed. And we tend to do what we know best, right? And we're very discipline specific. So what usually happens? Typically, a child would either see a dietitian in the community, a behavioral analyst, an occupational therapist, speech and language pathologist, or a physician or nurse practitioner. And as I said, we do what we know best. So the dietitian will say, let's try some supplements. The behavioral therapist, oh yeah, it's a behavioral thing. Let's put some behavioral intervention in place. Occupational therapist will say, sounds sensory to me. And a speech and language pathologist will look for oral motor issues to address. And physicians, we take up the rear and we'll order blood work, and then we'll decide to which of the clinicians we should do a referral to. Now, when we do this approach, what happens is that there's siloed care as well as inadequate care, and there's no collaboration. And we're dealing with one individual plus family members within their environment and a community. And if we're only working alone and not communicating, then our success rate is going to be quite limited. So let's look at a case. Here we have a 4-year-old boy with autism spectrum disorder who presents with picky eating resulting in limited diet of less than 15 foods. When a new food is presented, he cries and pushes the food away. His family sought help from an occupational therapist. The occupational therapist saw and explained that the child has sensory feeding issues and designs an intervention to help desensitize the child to some target foods. After several months, the child will touch and lick some new foods, but has not added any new food to his diet. So I want you to think for a bit. What else would you be thinking? What else should you be doing? So here's what we're missing. Our 4-year-old client has significant issues with constipation. He grazes all day, eats a few bites at a time. He's fed by others while walking around or while watching TV. His parents struggle with poor compliance in all areas, so sleeping, dressing, bathing. So think about whether or not any of these factors will impact that feeding behavior. And rightfully so. There are medical, environmental, and other behavioral issues that needs to be addressed first before even thinking of using desensitization or having a sensory approach. But our occupational therapist was working within their scope of practice and was looking at the problem through a sensory lens, but there were other elements that also impacted that feeding behavior. Next. So in 2017, we put together ideas of what we saw both in clinical encounter, looking at research papers and what research told us about the approach in assessing individuals who are presenting with feeding challenges. And then we developed what's called the MOBS framework or MOBS approach. And this is designed to guide clinicians through each factor. So MOB stands for medical nutrition factors. Then we look at oral and oral motor factors, behavioral factors, sensory, environmental factors to properly identify the cause or etiology of the child's feeding challenge. But this is grounded on the premise that parent-child relationship impacts all aspects of feeding and requires consideration as clinicians move through each element of the framework. Many of the registrants today would say, hey, isn't this similar to pediatric feeding disorder framework? So there are some similarities where we both look at nutrition, medical factors, psychosocial factors, and skills. But what's different with the MOBSy approach, especially for autistic individuals, is that we are really intentional in looking at behavioral factors, sensory factors, as well as environmental factors that could be impacting feeding. We have a publication that details a tad bit about what are some of the factors that we're looking at, and we're going to be walking through this today. So under the medical nutritional factor, there are common medical concerns that needs to be identified, and that we do is give some examples as well as red flags, as well as recommendations and literature to support each of the domains that we go through. So this would be a good check sheet to go through and paper to read, and also to critique and send us some feedback. Someone is asking for the screen to be increased. It's impossible to read. So let's look at the medical factors. So when we look at medical issues, many times we try to do a systematic approach, the way to identify medical contributing factors. But of importance, the things that we need to look from mouth to anus. So looking at dental caries are commonly seen and impact whether or not a child is able to eat, chew, and may have pain associated with that feeding behavior. And then we look for whether or not there are features of coughing, choking, or drooling with feeds that may suggest dysphagia. Gastroesophageal reflux disease or gastritis is also common amongst autistic individuals. And we have to also remember that its presentation may be atypical, especially 40% of autistic individuals are nonverbal, and thus may not present by saying it hurts, or mom, my mouth hurts, or my abdomen hurts. Instead, we'll be presenting with behavioral differences, such as hitting of the chest, hitting of the abdomen, or common presentation for constipation or reflux disease. It's also important when we talk about dental caries that there's that link as well with gastroesophageal reflux disease. So kids can have reflux and are quietly not being able to tell a parent that, hey, food is coming back in my mouth, or it hurts, or it burns. And if you're going to the dentist often with lots of caries, as a clinician, one has to stop and think whether or not there's a possibility of reflux. Food intolerance and food allergies are also important consideration. And then for sure, medication, because different meds can impact a child's feeding behavior. So we know that if you're on a stimulant medication, for example, Ritalin or Concerta, it can decrease your appetite, decrease your desire to wanting to eat, and that impacts your entire nutrition. And we know that if you're on an antipsychotic like risperidone or Abilify, it may increase your appetite, and that child is driven to eat lots of foods, and it might be lots of foods that are not necessarily rich in vitamin, but more calorie dense foods. Importantly, on this slide, we haven't done two honorable mentions. One concept to think about is also irritable bowel syndrome. This is commonly seen as well in autistic population and presents with abdominal pain, chronic abdominal pain, and change in stool patterns. So whether or not you have diarrheal stool patterns, change in the color of stools. And it's important to consider this. Again, as I say, lots of our kids are nonverbal and unable to tell us when they're having discomfort. So doing a behavioral history is also key in identifying whether or not that impacts or is associated with a feeding encounter. And lastly, new kid on the block, eating disorders, avoidant restricted food intake disorder is something for us to consider. We're still early days yet trying to identify how does autism spectrum disorder intersect with ARFID, but they will present with significant restricted food intake, which is not governed or driven by body image or fear of weight gain. Next slide. I think there's just some delay in the advancement of the slide. So as we see kids in the clinic, one of the things that we'd like to do is a physical examination. And one of the things that we ask parents to do is also a food diary, which is really important. So food intake, a vital sign. So it's important to ask parents to please document what your child has eaten. If you can get a 3-day food diary, that's great. 24-hour is also important to start that discussion, just to look at the variety of foods that are taken and whether or not the child ingests or eats all of the food. But some things that we do recommend, you look at weight, height, and it's not just a static measurement. It will be important to look at weight and height trajectory over time. So getting growth curves are important and looking at them to see whether or not there's crossing of centiles or even whether or not there's significant obesity that we need to deal with. Another thing that's really important for us is that we use the Bristol stool chart because we want parents to get comfortable looking at their child's stool, comfortable understanding that they can identify whether or not there's element of constipation and then initiate hydration as well as medication if needed. And so empowering parents is important. Important for us is that macronutrient intake evaluation. Our team also have a MOBS examination checklist, and we'll be happy to share that with you once that we have that available. But it's important for us to look at a child from head to toe, looking at skin, such as signs of pallor, yellow skin, dermatitis, petechiae, or bruising, because that can indicate vitamin as well as mineral deficiencies such as iron, folate, vitamin B12, or vitamin C. Looking at your nails, pallor, white coloring, clubbing, spoon shape, or curl nails can indicate iron or vitamin B12. Additionally, looking at hair, and I think for a Black person, you know, we talk about alopecia, and there could be many different reasons for alopecia, but alopecia, as well as the texture of your hair being corkscrew or coil, are also indications of iron and vitamin C deficiency. So it's important to ask parents, and it's also important to look at a child's hair and head to see if there are any indications of vitamin or mineral deficiencies. In your physical examination, doing a vision examination, looking for Bitot spots, which are foamy spots on the eyes, can indicate vitamin A deficiency. Looking at your mouth for angular stomatitis, bleeding gums can identify vitamin C, iron, or B complex deficiencies. And grossly, looking for ataxia, numbness, knot knees, bow legs are also indications of vitamin B12, C, and D deficiency. So a physical exam is not just anthropometric measurements, weight, height, BMI, but also looking at skin, hair, mouth, and pubertal stage to see if there's any evidence of amenorrhea in our youth. And lastly, even though we're in a resource-rich country, we do have food insecurity, and autistic individuals do have macronutrient deficiencies. So also brush up your knowledge on kwashiorkor and marasmus, because it does occur. There are case studies written, case reports. So lastly, just your checklist: look at your mouth, check for swallowing, look for food allergies, abdominal pain, constipation, and medication in your review list when thinking about feeding challenges in autistic individuals from a medical perspective. I'll hand over the presentation to my colleague.
Thank you, Dr. Smile. So I'm going to continue, and we're going to go through each of the sections of the MOBSE approach just to give you an idea of what we look at. So I'm going to go through the oral motor section, then I'll pass off to Christy, our occupational therapist, as well. So again, when my role really is looking at the oral motor piece and looking at oral motor challenges that impact feeding. You know, again, we always think about those anatomical differences that are more obvious: cleft or tethered oral tissues, and the structure of mouth and teeth. But it's also important to look at delayed oral motor skills. You know, what can they do with their tongue? What can they do with their lips? And that can lead to a mismatch of the food that's being offered based on a child's chronological age. Again, without looking so much at what their current oral motor skill level is. And we need to look at that even with autistic individuals where it may not be so obvious. Again, it's as I change it, it's a bit delayed. So I will talk as I wait for this. But we know that children with ASD are often later to transition to solid foods, and they often have more difficulty chewing. And they chew later than some of their matched peers. And when I get to the slide, you'll be able to see the reference for that. There's also studies that show a higher prevalence of malocclusion, so of some of those dental issues in children with ASD compared to their control groups. Others have found no significant difference, but again, we need to keep in mind things like chewing and things like malocclusion and dental issues when we're looking at children and why they may not be transitioning to solid food, which is always something that people are always concerned about. As a speech pathologist, again, when people talk about, is it sensory, you know, again, I work really closely with occupational therapists, and so I'm very sensitive to that. But at the same time, my question back is often, is it motor? And again, not accepting food, it could be sensory, but it could also be a mismatch, their mouth skills. It could be how fast they're being fed, so the pace, how much they're being fed, like how big is that spoon and how much is on that spoon, and then not necessarily responding or misunderstanding the child's cues or behaviors. So a child who's accepting a wide variety of smooth pureed food, there could be reasons why they're refusing or spitting or pulling out solids from their mouth. But I suspect if they're putting it in their mouth, but they may be having trouble with it once it's in there, I might suspect oral motor difficulties and look at that further before I would suspect sensory or behavior. But a child who willingly chews a selection of harder foods like Skittles or Smarties, gummies, for example, I may suspect behavior or sensory and not oral motor. And that's why it's so important to do further evaluation, because oral motor delays can look like sensory and vice versa. And it's important to figure out what is responsible for that challenge before we begin to treat. And the other thing we'll guide parents is if a child does have oral motor delays, they may need to be fed foods that match their oral motor developmental level and not necessarily their chronological age. So the goal may not be chronological, but it may be looking at where they're at developmentally. And so if we offer foods that are too challenging, these are some of the things that we might see: coughing, choking, gagging, vomiting. And many times people call those feeding aversions. But I guess the question often is, are they averse to feeding? Or are they averse to foods that may be too difficult for their motor skills? So assessment is important. It is really important that we get a good history of their feeding skills. What foods does that child eat well and willingly, and why? And what food does the child refuse or not eat well, and why? It is so important that we observe feeding. How often does someone tell you that they went into their doctor, and I'll throw doctors under the bus here. They've gone into their doctor and they told them about some of their feeding issues and they gave them some advice, but they never actually watched them eat. So it is really important to look at that child's overall developmental level and their motor skills, the oral mechanism structure, how their lip and tongue and jaw moves when eating, not just that they can talk, current chewing pattern, and their oral movements during speech. And so it's going to be based on the results of the assessment that we start to get an idea of what is going to be best to help a child. And the example I'll give, to work on chewing or to transition to textures, which is often such a big goal for many families. We talk a lot about these myth busters. And so people often come to us and they talk about their child having a swallowing problem. He's having trouble swallowing solids, so I'll refer him to an SLP to assess swallowing. But we don't swallow solids. And you know that. We chew foods thoroughly to almost a puree before we swallow. So if the child is swallowing liquids and purees, well, then it's likely not a swallowing problem, but more of a chewing or an oral management issue. Children may avoid foods that they can't handle, and if they can't tell us, that may be why. And so we need to assess their readiness to work on things. And just quickly at the bottom, kids can, if needed, continue to thrive nutritionally with purees and liquids. So it may be that those kids need to continue on those things nutritionally while we develop what we're going to do to work on chewing. Spitting out foods, it sounds like sensory. I should refer to an OT. But refusing can also be other things. What if they're being force-fed? You know, a mixed consistency, those chunky purees. Again, it's like puree surprise when you're swallowing a puree and then suddenly you hit this chunk that hits the back of your throat. So it is really important that we do a thorough evaluation and be sure that we know where we're headed. Another big important point to our approach is the behavioral approach and the behavioral side. And again, our BCBA couldn't be here today. So again, I'm going to talk a little bit about the importance of looking at those mealtime behaviors and really doing a good assessment, looking at, and even as a speech pathologist, my behavior team guides me to look at the function of some of those behaviors that people call disruptive, but they're often communicative. And what is the issues? And oftentimes families are quick to jump to feeding as the issue, but what other areas are concerning? And it's important to remember that there are two behaviors to consider, and it's important to watch the interactions because some of that may explain some of the behaviors. I'm going to pass this to Christy. She's our occupational therapist on the team to talk a little bit more about the sensory aspects that we look at as part of our assessment.
Perfect. Thanks, Rebecca. And thanks everybody who's joined us. I'm so impressed to see how many people are there watching in the chat. And I know we're in a time crunch, so I'm going to try to talk quickly, but hopefully not so quickly that you can't follow along. So if you're following along with the mobs, we're at the sensory area. And really in this area, it's our job to determine whether the child's experiencing sensory processing differences that may be impacting on their feeding performance. So the obvious things that we always think about, so sensitivity to taste, touch, texture, smell, how foods look. But we also need to look at whether difficulty staying seated for meals may also have a sensory component. And then the last thing, which I'll go into a little bit more in a minute, is some children have challenges sensing hunger cues. And so we also need to consider that when we're kind of looking at the sensory domain of the MOBS approach. So we know that children with ASD process sensory information differently. It's one of the diagnostic criteria for ASD in the DSM-5. And we also know that eating can be a really intense sensory experience. It involves perceiving information from all the different senses at the same time, so it can be easily overwhelming. Like Rebecca said, it's easy to assume that most children with ASD have feeding issues because of sensory issues. We've got a child with autism, we know they're going to have sensory issues, so we assume that their feeding issues might be related to sensory. And sometimes that's the case, but it's important, like Rebecca said, to look at whether there may be other factors involved. You can go ahead. So the first thing that I always ask myself is the problem really sensory? And this kind of overlaps what Rebecca talked about in the oral motor section. So many things can look like sensory issues, but they may not be. So the spitting of food, the gagging, pocketing or holding food, only eating a few bites at a time, difficulty staying seated while eating. So all of these things can be sensory, but they can also be attributed to other things like oral motor or poor positioning. So we really do need to ensure that the issue is not a medical, oral motor, behavior, environmental problem that may just be masked or look like a sensory issue. So what do we do if it is a sensory issue? So we've kind of looked at all the other things, we've ruled them all out. This might be hard for the OTs in the crowd to hear, but there really is no strong evidence to support that we can change how our brain processes sensory information related to feeding. So we can't make someone like a taste or a smell of food. We can help them sort of get used to it, but we're not going to change whether someone likes it or not. And despite the existence of so-called sensory feeding treatment approaches, so things like the SOS approach, there's no evidence to suggest that sensory intervention alone is going to be effective for treating children with feeding challenges who have ASD. We do have evidence to suggest that we can use sensory interventions in combination with other things. So we can use behavioral and anxiety reducing strategies to help kids learn to try new foods and to modify their reactions when they have an unpleasant sensory experience. So I always say to parents, probably 100 times a week, we can't make a child like a food. Parents always come to me and say, like, my child doesn't like foods. Well, I can't make them like it, but we can come up with strategies together to help make a child be more comfortable and willing to try a new food. And yes, sensory strategies may be part of that, but we also might need to use behavior strategies or anxiety reduction strategies to help the child feel comfortable and safe to try the new foods. So a lot of you may have heard, recently, this concept or this idea, it's okay, you can go ahead, of interoception. And it really is sort of the hidden sensory system. And there's lots more coming out now in the literature about interoception. And what it is really just that awareness of our internal body state. So it's that idea or that ability to sort of feel the inside of our body. So feeling sensations such as pain, body temperature, when your heart is beating rapidly, or you have butterflies in your stomach when you're nervous. And for us, in the context of talking about feeding, it's that idea of whether we can sense the physical sensation of hunger or thirst, or if we do have that sensation, are we connecting that sensation to what is going to fix it? So me, when I feel hungry, I know that if I go and get food, it's going to make me feel better. Lots of people, we're now learning, have differences in their interoception. So there's the area, if you guys are interested in the neuro side of this, there's the area of the brain that receives most of the information regarding interoception is the insular cortex, or the insula. And there's lots of studies now that have demonstrated the differences between the insula in autistic individuals and those without ASD. And we've also got lots of people now, children who are verbal and adults with autism, who can report that they don't really feel hungry, or they don't really attribute that sense of hunger to needing to eat. And so what does that mean for us as people trying to help these kids is we can encourage kids to be hungry by treating constipation and trying to reduce grazing and get them on a mealtime schedule. And we should definitely do those things, but we can't rely on hunger alone as a treatment strategy. So we can't say, well, we'll just stop feeding the child and they'll get hungry. So that alone is not a good enough strategy, because some children may have issues with interoception. Go ahead. So back to these myth busters, probably, once a week, I get a parent who says that, they tried to make their child hungry, or they were told by the doctor to just stop giving him his preferred foods. When he gets hungry enough, he'll eat. Kids don't starve themselves. Well, we do know that some kids with ASD may not feel hunger. They may not connect the feeling of hunger with needing to eat. That's that idea of the differences in interoception. And we know that some kids with ASD have extremely rigid behaviors that leads them to seek out familiar food, and they're actually afraid to eat anything new or anything that's slightly different. And so these children actually can restrict their intake to the point of being malnourished. Sorry, delay.
Yeah, I've got a delay here.
It's a big delay this time. Sorry, I know we're tight on time. We're almost at the end here.
All right, and I can keep going.
Okay, yeah, I don't have the slide, so sorry.
The next section that we're going to talk about is really looking at the child's environment. You know, and so it is so important that when we're assessing a child that we do look at the environmental factors that that do contribute to the child's feeding performance. And some of those Christy already had talked about, like mealtime schedule and grazing, distractions, tablet, TV, toys, which has become a huge challenge, positioning different feeders in different locations. But I think the one that we talk the most about and the one that comes up a lot for us is that parent-child relationship and how much we have to consider the parents. And it's, again, it's not a fault thing, it's not a blame thing, but the relationship and the sheer amount of stress that these families are under. And we need to consider the parent and not just the child when we're looking at assessing and treating. We need to consider parenting styles because parents have different ways that they interact with their children. And so it is so important that we be mindful of gathering information only from parent report. You know, there's been many times where we've met people where someone has given the child, has given suggestions to the parent and the child wasn't there, or the child was asleep. And so it's so important that we also get information from other caregivers or from the daycare staff or from other people that are involved in that child's life, but also from the child themselves, if they're at all possible. And we have learned so much from some of our autistic individuals who have given us a lot of good information on how things feel and why they do what they do. And observation is so important to see the whole picture. It is so important to observe, whether it's in person, whether it's by video, whether it's in a video that's been taken, that whole picture. So again, this is a series of myths. You'll be able to see this closer if you look at our slides afterwards, but there are a lot of things that people say which aren't helpful. And again, I think we need what we've talked about in terms of the MOPSI approach is just making sure that we break it down and make sure that even as a sole clinician, even if you don't have a full team behind you, as I am lucky to, that there's lots of things that we can do. And that we need to think about kids with ASD differently when they present with feeding issues and not just look at the feeding issue. We need to assess how severe is this? And we use our MOPSI framework to really guide our assessment. It helps me as a clinician think through, even though as a speech pathologist, I might look at one section, it encourages me to look at it all. It's important before we do anything to address nutritional deficiencies and any medical concerns, because doing our stuff first, it doesn't make sense if there are those other things that need to be addressed. And we really need to consider parental stress and parenting style, because that is going to be what allows kids and families to continue to make gains moving forward. And it allows us then to refer to appropriate services to rule out or to address those other factors. This is something that we're starting to put together, again, a working document that it allows like a sheet that you can use as part of your assessment to be able to go in and remember. We're building one that's similar, but this is what we use when we're looking at what are the different issues when we meet a new child, to help us remember to look at all the different pieces. And then as we move to treatment, this is what we use. So again, I'm going to pass it off to Courtney from Glenrose. And I think the way we got involved in this was that, you know, Dr. Smile and Christy and I were asked to do a presentation, but the more I spoke with Courtney and the more I spoke with Tara Ward as well, we realized that a lot of what we do is along the same lines and that we wanted to do this together. And so we've started off talking about our method, but I'm going to pass to Courtney now to talk more about the way she looks at things and then how they transition from their assessment piece to their treatment arm.
Thanks, Rebecca. I've got a lot of content, so I'm going to kind of I'm going to try to condense as much as possible, and then I think I'll run my case study over a little bit into the percolator time. So Dr. Spicer, just interrupt me when you want to stop and pause, and then we can transition, and I'll continue at that point if that works.
Great.
So,
you know what, maybe what I'll do, because I know some people will need to leave at 11:30. And so what we'll do is just indicate that the recording will be available. So if you're not able to stay for the entire time, but you would like to see the additional content, we will make sure that you have access to that. A reminder as well that certificates are available through our P's website and email. And we've been very glad to have everybody. So if you do need to sign off as we continue here, feel free to do that, and we'll make sure that you have access to the rest of the conversation. We will probably run into the percolator time. So Courtney, please don't feel that you need to cram everything into the next 7 minutes or so.
Thank you so much. Rebecca, could you just go back one slide? Okay, so here at the Glenrose, we are an interdisciplinary team, and we are always doing our assessments with speech pathology, occupational therapy, and a dietitian. And then we also have access to some psychology support and social work. So these bits of information that we need for assessment are collected across multiple individuals and in multiple ways. So this is kind of how I see us breaking down our Glenrose assessment format. So for me, I think it's really important to know what the initial reason for referral was. For us, referrals come through physicians, whether that's a family doctor or a pediatrician. That's giving us kind of that starting point of what's going on, why were they sent in. Then when families come in or when we're doing an intake over the phone, it's really important to dig in to understand what they're worried about, because oftentimes that can be different than the initial presenting concern. And then really understanding what their goals for seeing our team are. Sometimes their goals aren't realistic, but it helps us to meet them at where they're at that time and connect in a family-centered way that we can work together as a team to support that child and family. For us, the history comes from a combination of chart review. Here within AHS, we have access to Connect Care, so that's really helpful. And then we're also gathering information from the parent or caregiver to look at what happened in their feeding history, what's going on in the environment. So the same kind of components that Rebecca was mentioning, that those same questions that they're using. For the diet history, Dr. Smile had mentioned the food record and how that can be really helpful. So I did, in case you're unaware, there is a really nice form available on the PEAS website that's called the Pediatric Food and Drink Record. And that can be really helpful to get a good overview of what the child's eating and what their reactions to foods are and kind of get some idea on patterning. We do an oral motor assessment, which is often kind of completed throughout the appointment. Oftentimes with our kids with autism, it can be really tricky to have them participate well and imitate tasks or follow along. So sometimes those are just made as they're eating or doing other non-food related tasks. And then for us, we always ask, we do a meal observation or a food play time. So we ask parents to bring in their preferred foods so that we're able to see what they do well with, and then also their sometimes foods. So I would never get a parent to bring in like a total no food, because we're not going to force a child to eat, but those sometimes foods can be helpful to see what sort of reaction it gets with something that a child is less comfortable with. Okay, so now next slide. Thanks, Rebecca. Okay, so what do we do? We're gathering all of these little bits and pieces of information about the child and family, but what do we do with it? How do we organize and prioritize? So that was a thread that wove through really nicely through the Holland-Bloorview team's presentation, was prioritizing, and I think that's really important as well. So I chose this image of a gumball machine because I think it's a good visual for kind of how this goes. We've got all these little gumballs that are the bits and pieces that we've learned about the child and family. But when it comes time to turn the knob and get that goal to pop out at the end of an assessment, we want to know that we're getting the best possible gumball, the best possible goal. We don't want to just guess. So like Dr. Smile had presented, we need to look at that underlying medical concern first. We need to know, is there something else that's contributing to selective eating, and rule out those types of issues before we start looking at either sensory or motor. We need to use our clinical skill and expertise to really tease apart those common factors. Like Rebecca and Christy were saying, they really do overlap and interplay. So spend some good time digging in the assessment, looking at sensory versus motor. They are often both found in the same child. So we need to see what is influencing what do we need to do first. I also wanted to mention that it's really key to work with a family when we're selecting goals. We need to arrive at a goal together. And we really need to have their buy-in, because if the family's not on board with the goal, then the work is not going to happen at home, and everyone's going to be dissatisfied with the therapeutic relationship and progress. So sometimes families come in with really big long-term goals. They want their child to eat the same foods as the rest of the family, but that might be really big and far away from where they're at right now. So we need to help them to break down their big long-term goals into smaller goals that we can work on in the short term. So picking those bite-sized goals that can help them along the way. Something Rebecca and I talked about in our conversation earlier this spring is that it can be really tempting to give parents a big list of helpful suggestions to try at home. We're all really creative and smart clinicians, and we know all these little things that this helped this family, this helped this family. So often it can be really tempting to give them a big laundry list of suggestions and ideas. But this is actually really not helpful to families. In my experience, it can actually tend to overwhelm them with all the things we've suggested and can actually stop all progress and kind of stop them in their tracks. So this is where the prioritization comes in. You can always revisit the goals and look at new ways to provide strategies. Just be cautious of giving them too much at once. All right, next slide, Rebecca. All right, so we're going to move into a case study with a little kiddo that we've been seeing here at the Glenrose for several years. First, I'd just like to thank his family so much for giving us permission to share his case. Mom was glad that we could present him in these across this presentation and next week in the treatment presentation, and happy to share his info that he could help other kids and other clinicians to learn. So as I said, he's a complex kiddo. He kind of evolved over time. So I've got several slides that correspond to the times that he came through our assessment clinic and the recommendations that came out of each of those visits. So I'll do my best to condense a little bit. So here we go. Okay, so we first saw him. He was referred by a developmental pediatrician here at the Glenrose. Emil was already being seen for early developmental impairment. He had some speech delay and fine motor delay. And the reason for referral was that he had a limited food repertoire and selective eating. So probably similar to what a lot of you see with kids with autism. Of note, at the time of his first assessment, he hadn't yet been diagnosed with autism. Mom was worried about his nutrition and growth, and she wanted some strategies to help with his picky eating. He had a fairly limited repertoire. He would eat some crackers, a few types of fruit, cereal, baked beans, yogurt, milk, and vanilla Pediasure. So during a meal observation with him, we observed that he was using his tongue to mash fruits, and he would suck on cracker pieces until they were soft enough to swallow. And Mama also told us that breastfeeding had been really challenging, and ultimately he had only been able to use a bottle. Now, during the meal observation, we looked at his flexibility with his preferred foods. So we cut his fruit into some different sizes and shapes. We also tried some pudding on his plate as a non-preferred food, and we modeled dipping the fruit in the pudding and using it as a stamp. He would not touch the pudding in any way, but he was very curious and would watch us play with the pudding. So because of his limited food repertoire, when the dietitian took a deeper look at his history and assessed his nutrient and micronutrient intake, as is often the case for kids who rely in a large part for milk as their primary intake, his diet was low in iron. So because of what we had observed with how he was moving food around in his mouth during the meal observation and Mom's report of difficulty with breastfeeding, we were already kind of thinking, was there a tongue tie? And often we find that kids are really reluctant to have us poke around in their mouth, or they're not willing to copy those oral motor tasks. So usually we wait until the end of our appointment to really get in the mouth because they're going to cry. So we get in there before we send them off. And we did see that Emil had a significant anterior tongue tie. So the recommendations coming out of this first visit were that he go to ENT for consideration of tongue tie release because we felt that his tongue tie was significant enough to impact his ability to lateralize his bolus. We provided some strategies to Mom to work on food play and increase his comfort with non-preferred foods and increase exposure. We talked about the just noticeable difference as a way to work on flexibility with his preferred foods and talked about trying to expand his repertoire to other flavors of Pediasure, other shapes or types of crackers. The dietitian did recommend an iron supplement. We know that iron has an impact on appetite, so it's really important to kind of keep that in mind, as well as for all the other reasons that Dr. Smile mentioned earlier. So Emil at this point was attending a PUF program, and his team there was able to work on the food play at school. Mom felt like she understood and had a good sense of what was going on. So we sent them away with the recommendation to consider tongue tie release, and left it open that they could contact us if they had any concerns or issues in the future. Okay, next slide, Rebecca. Okay, so the next time he came in, he was 3 years, 10 months old. I'm going to condense a little bit. I think this is a visit that he came in with that I can take a bit of time out. So the reason he came back in was Mom was still looking for some help with expanding his diet and still continuing to be worried about his food repertoire and nutrition. He'd been dropping some foods and kind of picking them up, but some of his primary foods that he had dropped at this point were milk, yogurt, and baked beans. So you can see why she was concerned, because those are some big important sources of nutrients and protein. Mom and community team had been doing a really good job of working on strategies to increase his repertoire. He had a really good meal and snack routine. He was able to sit at the table with family when they were eating. He had been able to pick up other flavors of Pediatric over the last year, which was great. And they were working on a lot of sensory and tactile play, especially with wet. We did a meal observation and we observed him eating crackers and fruit, his kind of staple foods again. And he did have improved tongue movement. He had had a tongue tie release since the time of his last visit. Still some delayed oral motor skills. He was using kind of a tongue thrust swallow pattern and primarily munching with kind of some like early emerging rotary chew to break down his bites. Also some overstuffing was noted at that point. So the recommendations that came out of this visit, we decided not to make specific recommendations to work on those oral motor skills like chewing progression or jaw grading, because we were hoping that those skills would continue to develop over time now that he'd had his tongue tie release and as he was able to add more challenging foods to his repertoire. So our recommendations, we wanted them to continue on with the exploration and the sensory play. But he was doing really well with that, but having trouble getting from the out at the hands up to the mouth. So like Christy was mentioning, a sensory approach alone is often not enough for kids with autism. So we introduced at that point a rewards-based system with external motivators. So we recommended incorporating some cheering, bubbles, and dancing to help get that interest in the food interaction. So we wanted his team to start with non-food items and with the sensory play, introduce some food with this reward system, and then ultimately keep in mind that goal of fading out the reward. Because what we want is children to have and develop that internal motivation to eat and not rely on those external rewards. Using a reward-based system like this needs careful therapist supervision because there's a really fine line between desensitization and flooding. So once again, the dietitian was monitoring his iron levels and he was doing he was using Pediatric to supplement. Mom felt like she was happy with the idea of using this reward-based strategy and felt confident that she could bring that to his community team for some help. Okay, next visit with Emil. So another year later, we got another phone call from Mom asking if we could see him. She was concerned about his nutrition again, but the pediatrician wasn't concerned with weight and growth, but Mom felt like he looked skinny and had dropped some of his preferred foods again. He was working with a new OT at that point, and that OT was looking for some more input and for more strategies to work on diet expansion. He had been able to pick up a few new foods using a first then strategy that his community team had introduced, and Mom had continued to use those strategies we'd already introduced her to before. So they really were like a gold star family that were able to keep going with all of these things that we had suggested. Something that was a big change at this point was that Emil had been on and off of Prevacid for reflux over the last couple of months because the family had noticed that he had been spitting up. And then the volume and frequency of this regurgitation had increased the few weeks before he came in to see us again. Mom wasn't sure if the Prevacid was making a difference, so we asked her to follow up with the pediatrician. In addition to the regurgitation, that was a new change for him. Mom reported that she was noticing some coughing with fluids and some occasional throat clearing with solids. During our assessment, Emil was able to do really well in food play, was willing to touch and paint with pudding as long as he had a wet cloth to wipe his hands on nearby. He was drinking well from a Contigo straw bottle, observed eating crackers. His oral motor control still seemed a bit less than what we would have expected, still with immature chewing skills. And at this point, during this visit, we also noticed some signs of dysarthria. So he was using a telegraphic speech pattern, syllable reduction, atypical resonance. He had a resting forward tongue posture and imprecise articulation. Mom also brought up that he was drooling a lot, but he was able to slurp and collect his saliva on his own without cueing. So what we were seeing in the speech pattern kind of matched up with what we were seeing in the oral motor control of his mouth and his strength for eating. So a lot happened in this assessment, but because there had been the concern of the coughing and throat clearing and those change in GI symptoms, we did a video fluoroscopy as part of this visit so that we could better understand his swallowing physiology and determine a safe diet recommendation. The video fluoroscopy showed that he had a mild, moderate oral motor impairment or oral impairment characterized by reduced tongue control and a mild delay in the initiation of the pharyngeal swallow. The pharyngeal phase of the swallow was mildly impaired, characterized by reduced tongue-based retraction and residue in the piriform sinus after the study was completed. So we didn't see any penetration or aspiration during the study, but we hypothesized that he would end up aspirating on the residue that had collected in the pharynx that would trigger the cough response or the throat clearing. We also observed some mild residue in the upper esophagus and some retrograde flow of the bolus below the PES. So our takeaway was that his oral motor impairment was contributing to reduced base tongue retraction, which was what we need for pressure generation. So leading to some of the residue buildup and some mild signs of dysphagia. So we felt like he needed a further referral to GI to look further at the increased regurgitation of solids, his reduced intake of preferred foods, and as well as further assessment of his esophagus. Okay, so the recommendations, Rebecca, if you can push next one more time. Thank you. So the recommendations, like I just said, were referral to GI. We also at this point referred him for motor speech assessment and treatment through SROP here at the Glenrose. And his community team, we gave them recommendations to work on tongue and jaw stabilization, continuing to work on sensory play. We didn't want them to work on food chaining or expanding right now at this point because his GI status was unknown. So we don't want to be pushing children to eat foods that may be causing discomfort until we know what's going on. So we just thought stay with where they're at, and then once that was managed and he had been seen by GI, then they can continue to work on food chaining to keep moving forward. And because Mom had had some success with a first then strategy at home, we said she could continue with that with his sometimes foods. And then at this point, Emil he still had a really great community team. The parent had a really good relationship with the pediatrician. So we recommended these strategies and these referrals, and then left it for them to call us when there was more. So he did go to Peds GI. He was scoped and diagnosed with esophagitis, and he ended up being treated with omeprazole. And then also, kind of at the same time as that was happening, Mom was worried once we had pointed out a possible motor speech disorder. So she went to follow up with developmental peds to go back again to say, what's going on? Now we're seeing motor speech disorder. He's got some ongoing motor concerns. He is continuing to have some low tone dyspraxia, poor coordination and balance. So after developmental peds check-in, he was referred to neurology and seen by neurology. They sent him for an MRI, and neurology decided that he would meet the criteria for DCD, developmental coordination disorder. So he is a tricky kid. He's got a lot going on. Then as a result of the neuro consult as well, he was sent to genetics to see if there was anything else underlying these things that they were noticing. And he had whole exome sequencing that was negative. So they didn't find any underlying genetic conditions. Okay, we're getting there. So this is the point when he is 6 years old. So this is our most recent clinic visit. It was a virtual appointment, again, requested by mom. Again, he had dropped some of his staple foods, and at this point, he was mostly eating crackers and drinking milk and Pediatric. So mom was really worried about his nutrition. She was also worried because he was eating smaller portions of food than he had been before, even of his preferred foods. This was during the pandemic, so he had been kind of separate from his community team and hadn't had any services for a few months. Mom was still using that first then approach and was doing well. His regurgitation had improved since our last visit, but he continued to vomit about once a day and was still connected with Peds GI. Mom also told us that he was getting his permanent lower central incisors, but they were erupting behind his pediatric teeth. So he was ending up kind of with a double row of teeth a bit, and he appeared to be avoiding biting at the front of his mouth. So his community team had been having difficulty progressing him beyond those single tastes of new food. So they could get him to take a taste or a bite, but nothing was generalizing home. So mom was still using all of those great strategies, but just feeling stuck. He would take one bite and then it wouldn't progress. When we watched him eat during our virtual appointment, we observed him with a snack of dry Cheerios and water. He continued to show that immature chew pattern, predominantly munching, a little bit of lateralization, so still delayed oral motor skills overall. Okay, when we get to the recommendations, we decided that that approach of trying new foods in sessions, because that wasn't working, we needed to change approach and try something else. So we felt like there was possibly a few things going on at the same time that we needed to balance out and tease apart. Because his intake was decreased and he was mostly preferring Pediatric, why? It could be related to his mouth pain from those erupting teeth, or it could be some ongoing esophageal inflammation that he was preferring to have a mostly liquid diet. We also know that he has delayed oral motor skills, so maybe the foods he was trying in therapy were too challenging for his current skill level. And I think that's something that Rebecca and Christy touched on as well. So at this point, we recommended that they focus on spoonable foods and use a food chaining approach to build variety and flavors rather than working on discrete solids. We were hypothesizing that if the foods were easier to eat for him, that we would have more success in making that transition to accepting foods for his regular repertoire at home. So we also wanted mom to select more specific goal foods to work towards rather than using a chaining hierarchy rather than just playing with any food and having tons of exposure, because it seemed like he needed more of a targeted path. So because of this, the complexity of this kiddo, and we had set up this new treatment approach where we were going to work on food chaining with spoonable foods. At this point, we sent in a referral to the treatment team through SROP Peds here at the Glenrose for a burst of feeding therapy. So when we do that, the treatment team likes to receive from us our reports, our observations, and also for him to show up with a bit of a goal. So the treatment team wants to know what is the short-term goal, because they do discrete bursts of treatment. So we sent him over to that team, asking them to support this new treatment approach with expanding spoonable foods and smoothies. We asked for some help working on oral motor skills like tongue control, chewing progression, and start with an intensive burst of therapy at the Glenrose and have them transition those goals and treatment plans to his home-based team. So that's kind of where his case study ends. And then next week, the group will pick up and talk about the same child and what his treatment program was like through the service here at the Glenrose. So just to wrap myself up super quickly, what are the takeaways from this case study? So I feel like his case in particular really showed the importance of prioritizing those goals and then reevaluating along the way for progress and deciding what the appropriate next step is. Feeding assessment is a really dynamic process. There's a lot of information to collect, and it's really common to get that information over time and across multiple visits. I'd like to point out that you don't need to be afraid to pull back and try something else. As you've listened to this case study, I hope you heard lots of, we recommended something that then the next time he came in, we wanted to change approach and try again. So it doesn't mean that the prior recommendations were wrong. It just means we use that information and make a next plan. And then importantly, something that I always use as part of my practice, and I heard Dr. Smile say it as well, is ask what else. So this is really important when we're working with these, especially complex kiddos and families. We need to keep digging, and we need to get to the bottom of what do they really need to have an impact, and what can we do? All right, that is it for part 1 assessment. Thank you.
Well, thank you all. This has been really tremendous. I've learned many things. It's been pointed out to me a few things that I do in my practice that I perhaps should reconsider, and really shows that some of the teaching I had, which is now, many years ago, is really certainly not up to date. I had to chuckle when I heard the statement, a child will become hungry enough to eat. Well, we've certainly realized that that is not always the case. And so I need to relearn and teach future generations of practitioners as well some of this new thinking. That one I've given up on a long time ago, but there were other examples today. I really appreciated the MOBC approach, and really also appreciated how that was supplemented by the case study and really looking at a child's progression over time. So I think the collaboration today proved very successful. In a moment, we'll turn to questions and comments. I do want to remind people that part 2 of this will take place on November 2nd. So I'm very hopeful that all of you can rejoin with that again as well. So we will turn to our question and answer at this point in time. I'm going to be assisted here by Melissa as we queue up the questions. I'm going to ask some of the questions as they appear in the order that I have them. And Melissa, you can feel free to interject and add questions as well. One of the questions is, do you see a correlation with kids gagging in response to textured food introduction and an absence of mouthing toys and other objects in infancy? Do you see those things correlated?
So I can start, and then Courtney, if you want to keep going. Hi, Nicole, how are you? I will say that it's both. And I will say sometimes that we definitely do see those families that tell us that they did not mouth toys and other objects in infancy, and then we go on to see them struggle. But we have others where they will put anything in their mouth as long as it's food. And so they did actually have an appropriate sort of mouthing of things, but then as they got older, something changed. And so I really think that that's an important thing to keep in mind, that question of developmental stages and did they go through those typical stages is so important to know, because it starts to give us a clue as to what might have gone on.
Yeah, I would agree with what you said, Rebecca. I think I do see that correlation, but like you said, it's not the only reason why I would see gagging with textured foods. So I think, yeah, it comes up as a little red flag for me when I'm interviewing a parent and I might hear, no, they didn't put anything in their mouth. I could leave them in the floor, in the middle of the floor, and be totally happy that they wouldn't try anything. And then I'm always like, oh, that's not good. So I think you explained it well, Rebecca.
Great, as always, variation in these, but it's interesting to see the themes. Is there evidence, this is now a question from Christine, is there evidence suggesting that lack of hunger sensation is present during infancy? Or is there an age when this tends to be first observed in children who are eventually diagnosed with ASD?
So Christy had to go, and she is probably the best one to answer this. The other panelists may have something that they want to add in. I mean, I think what I can say is that we know that in infancy, there are certain things that are reflexive. And so oftentimes we don't see this in early infancy when things are reflexive, but that we see it as they go along. Dr. Smile, I don't know if there's anything that you want to add, or Courtney, but it tends to not happen immediately in infancy, but we do have families that tell us that things like breastfeeding were hard, and that even figuring out the right bottle was hard. So then it's this question of, is that the hunger sensation, or was it something else that was challenging for them even as infants?
Yeah, and I agree with that, Rebecca. And I just wanted to add, many times we look at behavioral presentation to indicate that there might be some impairment in hunger signals, right? Whenever a family reports that he never comes asking for food, he could go all day without seeking out food. So as our occupational therapist is going through that history and we're listening, we're looking for behavioral changes and patterns to identify if that's a factor.
Along the same lines, and asked by the same participant, what are some potential intervention strategies to address lack of hunger sensation?
So that's a hard question. What we tend to do is, as many things with autistic individuals, just routines, right? So starting with routine, knowing that we want kids to have breakfast, lunch, dinner, right? Have limited snacks in between would be one thing. But I think when we speak to older, so adolescent youth who say, hey, I'm not hungry, there's absolutely nothing that we can do to change that. Because there is some response, whether or not there's interception being a factor happening there. And what we have to look at is, were you nutritionally, what calories do we need to get in? And if we can have that discussion with the youth and get them on board with routine, that's fine. But for preschoolers or individuals with intellectual developmental disability, I think we go back to that
I don't know if I'm the only one, but Dr. Smile, we lost the last little bit of what you said there. But I think we caught enough of it to get the answer. Thank you for that. The joys of doing this by Zoom.
And Tara has added in the chat that she's going to be talking about that more in next week's presentation as well. So interoception, some treatment with establishing consistent mealtime routines, vocab to introduce hunger. So those will be things that she will address more next week.
Great. Here's another question that is kind of along the same lines from somebody who identifies themselves as an RD and has seen many kids with ASD that are only able to eat with TV or distractions or walking around. I know that this should be avoided when eating, but if the child won't eat otherwise, how do you navigate that?
So can I start, Courtney? You can keep going.
Yeah, go
I would say that those are two different things, the TV and distractions, and separate from walking around. But both of those are things that we're going to have to work on skills. Again, they clearly are using those for a reason. If we tell families don't do it, they'll just do it and not tell us, because there's reasons why the families are doing it. So, I mean, the first thing is to ask why they do it and what's the reason, because often we need to work from where they're at. We may work then on those skills, but not at mealtime. We may work on it at a snack time. It's a skill, just like any other skill that we're going to build. Families want to get food in during mealtime. And so sometimes it's hard to change that, but we can begin to have them sit for their favorite snack and not walk around for that favorite snack that we know they like and work up to it. They may need those distractions for a while we build more foods, but as they start to do more things and are eating a little bit better and families are feeling better, then we might be able to move to a less exciting distraction or music in the background. But these are, again, as I talk, these are behavioral strategies. These are family, dynamic strategies, not just eating strategies.
And I think I was just thinking from the perspective of assessment, it's like getting more information around all of those things too, like when did this start? What happens at school? Do they need to be wandering around and distracted at school? Like digging into the whys, and that's how you can help to pull apart how do we need to address this, and what are the things that are perpetuating this behavior?
I'm kind of going through these questions a bit thematically as we go. And one of the comments was that a parent reported that their child's food repertoire changed significantly after an illness. Do you see that commonly?
Yeah, we definitely see that a lot. And sometimes those patterns can last way longer than you would have expected based on what the illness was. So certainly that's something that we see. They've been eating a whole bunch of things, they've been really sick, and then now all of a sudden they only want, their comfort food items of like goldfish crackers and milk or something like that.
Any particular strategies, or do we use the same framework?
I think the strategies bridge more into treatment, which we'll talk about more next week, but I would recommend as a short answer, just continuing to have like a set meal and snack routine and bringing the other preferred foods that they've dropped back fairly regularly without forcing the child to eat, but it's just that repeated presentation, having them available. That would be a helpful strategy to hopefully help them bounce back after illness.
And I just want to put a plug, because many times kids will have an acute illness and stop eating everything and may limit things to liquid. So we need to do some parent education to seek ER or go to your doctor immediately and not wait and watch to see whether or not they reintroduce foods. Because when we look at patterns of kids admitted to the hospital, it's usually post an illness, a viral illness, having vomiting or diarrhea, and they will not eat for many days. And so it's important to make sure nutritionally that they're still stable and taking enough and not ill.
Okay, there are so many excellent questions here. I would love to be able to answer them all. Unfortunately, we will not get to all of them today, but perhaps what we can do is respond to them with a written answer and post them on the PEAS website. One question that I would like to put forward before we end our session here is, do you find the MOPSI framework useful in children who have diagnoses other than autism?
It's not even my framework, but yes, we're all nodding. Yes.
Yeah, I think that was the cool thing, that as Courtney and I talk more and more about what she does there and what I do here, we look at the same things. And as a clinician, that was where this came from, that we came from putting our heads together and realizing that these things were important. But so often people were coming at us with a question about, something that was dietary, and I was saying, wait a minute, or we were talking about sensory, and then there was something else where, Christy and I really needed that medical side of it. And that's really where that came from. So yeah, I think it guides us not just in children with autism, but in our general feeding clinic as well. We are going through that in our minds as well, of the medical things, the oral motor. It's important for us to do a good assessment, and no matter what we do. And for some reason in feeding, we don't always do it. And that's the way we were trained to assess everything else. And we do it for this as well.
I think that's a great comment for us to end this presentation on. I really want to thank all of you, Christy, Courtney, Rebecca, Dr. Smile, and all of the other collaborators who came together to plan and put together this session. And thank you, all of you, for attending today, for your excellent questions. We do look forward to further conversation in a week's time to learn more about treatment options. And the sign up for that was posted in the chat, and will also be available on the PEAS website. So thank you, everybody. And quite fitting, it's time for lunch, at least here in Alberta. In Ontario, where our presenters are, 3 of them anyway, it's probably time for your mid-afternoon snack. So on that note, thanks everybody, and we'll see you hopefully in a week's time.
Thank you so much. Bye, everyone.